The first case is a case of a young male who presented to us with retinal detachment and PVR contraction under oil. The surgeon performed PVR dissection under oil without removing the silicone oil. The infusion was switched off during the entire course of surgery. 25 gauge and grasping forceps was used to meticulously dissect the PVR membranes. Persistent posterior hyaloid was completely lifted up from the retinal surface using the forceps. This was followed by removing the hyaloid membranes using vitrectomy cutter. Once the vitreous was removed, then the surgeon created an inferior retinotomy. Subretinal fluid was removed actively using the blunt tip 25 gauge cannula. Lastly, inferior retina and retinotomy were lasered adequately. This was followed by injection of additional silicone oil to provide adequate retinal tamponade. Post-operatively, the retina was successfully attached at 2 months of follow-up with best corrected visual acuity of 4/60. The second case highlights management of unexpected intraoperative complication in a case of old retinal detachment with multiple subretinal bands. End grasping forceps was introduced through the retinotomy to hold the subretinal band. During this maneuver, surgeon encountered subretinal bleed which migrated underneath the fovea. The surgeon immediately put PFCL on the posterior pole to help displace the bleed from the fovea. The bleed still persisted and was not displaced. This was followed by BBG assisted ILM peeling. Later, the PFCL was removed, an inferior retinotomy was made, and the clotted blood was successfully removed using the vacuum of the cutter. The blood was gently sucked out from underneath the retina, preventing the enlargement of the retinotomy site. Once the blood was successfully removed, further surgery was completed in an uneventful manner. The last case highlights how the surgeon managed a case of an old retinal detachment complicated by subretinal air migration. This highlighted an extremely stiff and taut peripheral retina. An initial attempt to remove the air was made through the inferior retinotomy, but with fail. Finally, surgeon decided to perform relaxing retinectomy under air. Even despite performing a large inferior retinectomy, the retina was still stiff and was folding over the superior retina. To encounter this problem, the infusion was again switched on. A 360 degrees relaxing retinectomy was completed. This was followed by flattening the retina using PFCL liquid. Once the retina was flattened, a 360 degrees endo laser was completed. And finally, a PFCL oil exchange was done. The retina was successfully attached at 3 months of follow-up with best corrected visual acuity of 3 by 60.